I would like to welcome everybody to today's webinar titled Communicating Information to Cancer Survivors and Their Providers. My name is Scott Mash, and I'll be joined today by Ms. Cathy Costello and Emily Bunt. We would like to remind everybody that this presentation and associated documents are funded through the CDC and ODH National Comprehensive Cancer Control Program, Cancer Survivorship Activity Supplemental Funding Opportunity DP 17-1701. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of the CDC or ODH. For those that are just joining, if you could please mute yourself as you join, that would be wonderful. We're trying to keep everybody muted, but sometimes we fall a little bit behind on that, and it helps us eliminate background noise. So I would like to provide a little bit of information on our speakers today. Ms. Emily Bunt works for the Ohio Department of Health and has over 10 years experience in public health research and evaluation. She currently serves as a Researcher 3 for the Comprehensive Cancer Control Program at the Ohio Department of Health. In this capacity, she's responsible for developing and writing documents related to cancer surveillance, special reports on specific cancers, and the other cancer-related publications, as well as managing the development and implementation of the evaluation of the CCCP. Emily received her Bachelor of Science in Interpersonal Communication from Ohio University, go Bobcats, and a Master's of Arts in Industrial Organizational Psychology from Xavier University. Ms. Cathy Costello is an attorney specializing in medical legal work who has been involved with the Ohio Health Information Partnership since its inception in 2009. Through her ongoing work as the director of CliniSync Plus, Cathy continues to work with physician groups, hospital systems, and critical access hospitals to assist them in moving forward with the new CMS and Medicaid initiatives. Just a reminder, folks, please mute yourself when you join the meeting. Cathy is focusing on coordination of care issues between primary care and behavioral health and drug and alcohol treatment providers. She's involved with privacy and security issues in healthcare through her role as a commissioner for ENAC, the Electronic Healthcare Network Accreditation Commission. And my name is Scott Mash. I joined CliniSync in 2014 and am the director of consulting services and HIE outreach. I'm active in CSO HAMS, received my BS in computer science from Ohio University in '94, and my Master of Science degree from Duquesne in 2012. Again, thank you all for joining today. At any time, if you have a question, please do enter that question in the chat box. As I shared earlier, we are recording today's session. It will be posted on the CliniSync YouTube page in several days. Also, before we get started, last point, hang on to the end of the webinar because we will be mentioning a roundtable that's scheduled for next Tuesday, June 23rd, which will be focused on the survivorship care plan and related topics. With that, I will now turn it over to Emily. Give me a second here, Emily. Let me get you unmuted. Okay. You are ready to go.
Okay, thank you. Thanks, Scott, for that introduction. Again, my name's Emily Bunt, and I'm a researcher at the Ohio Department of Health in the Comprehensive Cancer Control Program. The Ohio Department of Health has contracted with CliniSync to work on the technical aspects of creating and sharing survivorship care plans. And they asked me to provide a context for the work they're doing and also to talk a bit about our program's goals and priorities. Our Comprehensive Cancer Control Program is funded by the Centers for Disease Control and Prevention. CDC funds programs in all 50 states, the District of Columbia, 7 U.S. islands and territories, as well as 8 tribal organizations. And they provide us funding to implement impactful, strategic, and sustainable plans to prevent and control cancer. The program has 6 priorities, including the primary prevention and early detection of cancer, building healthy communities through policy systems and environmental approaches, promoting health equity, demonstrating outcomes through evaluation, and of course, supporting cancer survivors and their caregivers. The next slide, please. The past year and continuing for the next 2 years, our program has received and will be receiving additional funding to focus solely on cancer survivorship. With this additional funding, we are required to implement 5 strategies or activities. One of those is being to use local cancer registry or electronic health record data to create survivorship care plans for distribution to cancer survivors. And this is the work that we've partnered with Cathy and Scott to help us with. Next slide. I know I'm likely preaching to the choir here, but focusing on cancer survivorship is critical. 5% of Ohioans are cancer survivors. This includes people recently diagnosed with cancer who are in active treatment, those living with cancer as a chronic disease, as well as those who've been living cancer-free for years. Last year, there were 580,000 cancer survivors in Ohio. And we expect this number to significantly grow with the growth and aging of the population, and also with increases in survival due to changes in early detection practices and treatment advances. And 66% of Ohioans diagnosed with cancer survive 5 years. And you'll see on this slide a link that will take you to our fact sheet on cancer survivors that the Ohio Department of Health produced for the month of June. Of course, with June 7th being National Cancer Survivors Day. Okay, next slide, please. Survivorship care planning is needed, especially when you consider that cancer survivors are more likely to report comorbid conditions compared to adults not diagnosed with cancer. According to the 2018 Ohio Behavioral Risk Factor Surveillance System survey, cancer survivors are more likely to report obesity, depression, diabetes, lung disease, and heart disease than those not diagnosed with cancer. In addition, 38% of cancer survivors report that their health is fair or poor. 19% of cancer survivors reported that they had 14 or more days in the past month where their mental health was not good. And 22% reported that their physical or mental health prevented them from engaging in usual activities. Next slide. There's a need to focus on the physical activity and nutrition needs of cancer survivors. When you consider that 36% of cancer survivors report no leisure time physical activity, only 13% report meeting aerobic and muscle strengthening guidelines, 35% report fruit consumption of less than 1 serving per day, and 16% report vegetable consumption of less than 1 serving per day. And again, this is according to the Ohio Behavioral Risk Factor Surveillance System survey in 2018. Next slide. Another major focus of our work in the Comprehensive Cancer Control Program this year has been on revising Ohio's cancer plan. Next slide. Ohio's Comprehensive Cancer Control Plan is a strategic plan to reduce the burden of cancer in Ohio. The cancer plan provides guidance to individuals and organizations that can play a role in controlling cancer. It addresses several aspects of the cancer continuum, including primary prevention, early detection, and of course, patient-centered survivorship services. And the plan is intended to direct collective efforts toward achieving specific and measurable objectives. Next slide. In our current cancer plan that extends through the end of 2020, one of the goals is to improve the lives of persons diagnosed with cancer and their support systems. And we have several objectives to support this goal. One of those being to improve the rates of delivery of patient-centered services in accordance with the American College of Surgeons National Standards of Care. Next slide. The current cancer plan is for 2015 through 2020. Our goal is to have a new plan in place by January 2021 that will extend through 2030. Next slide. We decided this time around to have a 10-year plan really for several reasons. One being, it's just a huge undertaking. It's a year-long process or more to revise the plan. We also realized that we're not likely to see significant progress towards achieving some of the objectives in a 5-year period. And of course, we are going to allow the opportunity to evaluate and adjust course if necessary anytime throughout that 10 years. The statewide cancer coalition, called the Ohio Partners for Cancer Control, is the group that's responsible for revising the plan. The Ohio Partners for Cancer Control has engaged a wide range of stakeholders to serve on topical work groups. Next slide. We have around 20 topical work groups tasked with developing objectives and strategies for the new cancer plan. There's a topical work group focused on the delivery of patient-centered services and access to survivorship programs and community resources. We also have a topical work group focused on hospice and palliative care. We are currently in the process of reviewing objectives that were submitted by the topical work groups earlier this month. We have a meeting of the Ohio Partners for Cancer Control in early July. And at this meeting, we hope to share the final list of objectives that will be included in the plan. Next slide. In July and August, these topical work groups will then shift their attention to developing evidence-based strategies to achieve the objectives. And we hope to unveil the completed plan at our November Ohio Partners for Cancer Control meeting and really begin at that point to implement the strategies as well as focus on sharing the new plan with Ohioans. So I really hope I've been able to provide a context for Cathy and Scott's work and share with you our program's priorities and some of the things we've been working on with regard to cancer survivorship. So next I'm going to turn the floor over to Cathy and Scott, who are going to share the work they've been involved in over the past year. Thank you.
Thanks so much, Emily. And I have to say, Emily has been a great partner in getting this whole project up and going and giving us input in what is going on. The other group that I have to say a big thank you to is Marietta Memorial Health System, who provided just many, many hours of support to Scott and me, educating us about cancer survivorship programs and plans, and more importantly, for what we were trying to do, talk to us at some depth, along with their vendor, about the technical challenges in creating cancer survivorship plans in different systems. So thank you all out there. We really appreciate your help. So let us move on. I think virtually everyone here does know what a cancer or what a survivorship care plan is, but the official definition from CDC really covers cancer treatment history, anything that is supposed to be done in the future as far as checkups and follow-up, tell the patient about any long-term effects, and give them ideas or resources for staying healthy. The American Cancer Society focuses in their definition also with the concept that they want this information to be available to future treating providers. I'm going to guess that that definition was probably created kind of separately from all the other technical reporting programs that we have that provide information, clinical information now, to subsequently treating providers. But that definitely there are two specific areas of focus for the survivorship care plans, one being for the patient themselves, to give them the documented history and the resources as to what to do going forward to get support. And the second is the future subsequently treating providers. The survivorship care plan, the one is we worked on this project, which has gone on for just about a year now. We kept coming back to what had happened with ASCO, the American Society for, let's say, Cancer. I'm sorry, don't have, but ASCO is really a subset of the oncologists who've been involved with creating cancer survivorship plans. The program, they identified the need for survivorship care plan as long ago as 2006. And since that time, it has really been a struggle from the technical perspective to try to create a survivorship care plan that was fully interoperable, because we all know that it really is the goal at the federal level right now, is to create as much clinical information as possible so it can be pushed out and shared by other treating providers. So in looking at this, ASCO actually developed one of the earliest of the forms that was designed to give elements, make them interoperable, make them able to draw out of the EHR system. They did this in the certified EHR systems that could produce certain technical fields and combine it into a document. The problem here is that the survivorship care plan has a number of fields that are not included in what we consider to be standard discrete data that can be pushed in what's called a continuity of care document. So we'll look at the continuity of care document in just a second, but I did want to just focus you on the ASCO form since it is so widely used. It is modified, it's used as a template, and was used as the underpinnings for what was called Journey Forward, which was a web-based survivorship care plan that quite a few of you all either used or used as the starting point for what you were doing in creating your care plans. As you can see, a lot of the information is fairly straightforward, is information that you would get out of your electronic health record system easily. But when you start getting into the specifics of the treatment summary, this is where you kind of get things diverge depending on which EHR system you're in, whether the system is integrated with your overall, whether your oncology system is integrated with your overall clinical system, will determine how much of that information you can move electronically when creating a survivorship care plan. So this is pretty much with modifications. Everyone that we talked to had modified the form, had done their own information. Obviously it changes depending on what the diagnosis is, what type of cancer is involved, but also on the organization and how much information is available to them within their system. What both CMS and CDC's goal at the national level, as we had mentioned, is really interoperability with all treatment information, all clinical information. If they could wave a magic wand, they would make any information for any patient that is seen by a provider available for all subsequently treating providers. The problem that we saw and you all live with every day is that because of the complexity of cancer treatment, it is very difficult to make it as able to be modified or fit into these nice, neat little buckets that you see when you're dealing with most certified systems, because there is not a separate certification for oncology EHR systems. And so that was certainly a limitation from what we saw, and from listening to all of you, I think it's probably a limitation that you too see. Part of the problem is, even if they would create a certification system for oncology care EHRs. The reality is the mapping would be extremely complex to do that. And Scott's going to tell you, Scott, as you all know, is my technical arm here, and he'll go into that some more. But that, you know, when we were about ready to beat our heads against the wall on this project, you know, about halfway through, that's what we realized, is that this information is so complex. Even if we could get to a system that was able to had mapped every single field to make a discrete data that could then pull into a continuity of care document, which we're going to look at next, it still would not necessarily mean it would be interoperable, because it would require the electronic health record system at the receiving end to be able to be mapped to exactly the same specifications. So those were some of the technical issues that we had. And here's Scott's going to explain where we're headed with this from the technical goals. But just to kind of set the stage for it, you saw what the survivorship care plan looked like. And here's the continuity of care document. Now, the continuity of care document, as those of you who are techie on the phone are aware of, is really the format that is used to push documents between, unlike EHR systems, in between providers. Because what it does is it has established fields and that are listed here. You can read down the list. You know, it has the patient identified information, problems, procedures, vital signs, allergies, meds, you know, goes on. It's a standard list. Every system in the country is certified to use the same fields to create their continuity of care documents. So this was part of our goal, is to see how much of the continuity of care document overlapped with the survivorship care plan, and hopefully Scott could wave his magic wand and make everything work just great, and that we could feed all that oncology specific information into the continuity of care document. So with that, I'm going to turn it over to Scott, and he can explain what really happened.
So first, we're going to start with talking about our goals for the project. But really, before I get started, I also want to take the time to thank Marietta Memorial Health System for partnering with us on this project. We spent countless hours shoulder to shoulder working towards the project goals. And in addition, we also want to thank OSU, SOMC, Ohio Health, SERMC, and a few others for providing some information that we also incorporated into the associated project white paper. All right, let's talk about this project. Our goal that we had proposed to ODH and Emily was so simple, or so we thought. Our goal, we were going to demonstrate that the required information contained in the survivorship care plan could be made interoperable on one or more of the more popular cancer-specific EHRs that we have here in Ohio. We'd hope to edit the document templates to pull in all the missing data points and then make that document available to the patient via the patient portal, include that same information in the CCDA, so then that information could be sent to other providers of care via the direct protocol, you know, supporting true interoperability. And then we also wanted to make that same CCDA that's sent via direct available within the CliniSync HIE, so that then the information is available for all future potential providers of care for that patient. Unfortunately, we quickly discovered that those were some lofty goals. So here's what we ran into. In the specific case of Electa, which has actually two different modules. There's a module called Mosaic, which is the full functioning cancer-specific EHR. Then there's another system called Metric, which is the cancer registry system. The information that's typically stored in these cancer-specific EHRs generally focuses solely on the treatment of cancer for that patient, but not the other conditions or appointments or procedures not really related to the cancer care. The metric system, again, it's a very limited data set. That's the cancer registry system, so it has some information about their diagnosis, about the patient. But again, are separate and discrete databases, even from the same vendor. So all of the needed information. In addition, there's other information that would be needed in the survivorship care plan, which is stored in the general EHR.
So three different sources.
So we got at least three different sources of data, and often there's a fourth being paper. For some of these charts. So.
But in some of the vendors, we're really happy to talk to OSU and Ohio Health because they both use Epic and they help implement numerous rural sites around the state on the Epic system, and the Beacon is their oncology system. And we were amazed at how much better integrated it was. So I think that just represents differences from one vendor to another. It takes you back 10 years ago when the whole movement to electronics started, and we saw such huge variations among different vendors. And again, in this area, I'd say the same thing. It depends on which vendor you're working with on how much you can make your process truly electronic so that you're not having to enter everything manually.
Yeah, so what we tried to do is, when we sat down and we looked at across the three systems, we're like, okay, can we move information around with these three systems? The answer is yes and no. There are some interfaces that allow you to move certain documents or certain limited data sets around, but the information either wasn't complete, the interface was too costly, or just took so many resources to implement that it really wasn't going to be feasible. So then we turned our focus to somehow getting the information needed for the SCP or the survivorship cancer survivorship cancer plan into a single system. So we thought, okay, let's see, can we have somebody collect this information and then key it in? Yeah, it's not the best approach, but there is a way that within Mosaic that you can build what's called an assessment as a means to capture the data that's entered as discrete fields that we could then pull into the survivorship care form or care plan. Here we hit several hurdles in that it would take a great deal of resources to do the research, collect the information, and then get it entered. And then even then, once the data was entered into the system as a discrete field, we really couldn't include it in the CCDA because those templates, the CCDA templates were delivered by the vendor and you could not modify those CCDs to pull in other information. And also many of the data points that are contained in the survivorship care plan do not have a corresponding field in the CCD. So we would have to either utilize one of the CCDA fields for something other than it was originally intended, which causes mapping issues, or we just got to try to find a way to make it fit or include much of the information in a narrative. But even including that information in a narrative, yes, that does share the information with the next provider of care, but it's not really truly interoperable because many of those fields would just be a general text that could not be extracted. So we also attempted to find a way to share documents that were something other than a CCD, some other document types. Well, many of the patient portals do allow for sharing of certain document types outside of a CCD, but it's really, really limited to very specific documents or workflows that we just couldn't utilize for this purpose. We also found that some EHR vendors limit what can be sent and received in a direct message. Some vendors will only allow a CCD to be the only element or the only thing contained in a direct message when it's sent. You can't attach a PDF, you can't attach another document type. Some EHRs allow for that, but for true interoperability, we have to go to the same standard for everybody. So that just wasn't an option. We also found that the cancer-specific EHRs tend to be a bit more behind the more general EHRs with respect to interoperability and related function. One cancer-specific EHR vendor we looked at had no interface that would allow sharing of a CCDA with an HIE. They did not have that data contribution interface. Back to Epic, one thing we noticed about Epic is Epic was able to overcome some interoperability so long as it was an Epic to Epic transfer. The survivorship care plan in Epic can be shared but it can only be shared with other Epic sites. It's a limitation of just of the functionality they can share through the Care Everywhere. Yeah, but then the document really couldn't be shared out beyond that. So
Except
yeah, as a PDF, but then again, you know, many of the EHRs don't allow you to hit a PDF or send a PDF. So these are kind of some of the challenges outside of the technology challenges that I just mentioned. There were a lot of other barriers or hurdles that we ran into.
Yeah, the accreditation issues was something that we early on got educated on by people we were working with. And that is because in the whole area of oncology certification, the standards are changing. And the Commission on Cancer, who is probably the largest accrediting body, we're really sitting on the cusp of moving into a new set of standards, which are going to be used in 2021 reviews. So they're the 2020 standards set up for next year's reviews. And in these standards, it was the Commission on Cancer that had originally adopted survivorship care plans as part of the requirement for cancer centers who are getting accredited. They had to, at a certain level, 10%, 25%, 50%, 75%, they kind of increasing totals, had to have their patients have cancer survivorship forms. And so all use sites that we talked to had worked under this original accreditation and had created the survivorship care plan in one form or another, recognizing that you were challenged in a lot of cases by the amount of time that it took to create it at a manual level. But you were creating this, a lot of you continue to use it, even though the Commission on Cancer has rolled back that requirement. And this is where you all are going to be coming in next Tuesday and giving us feedback, because what Commission on Cancer did, and I think it was in large part due to organizations like you all, who had gotten engaged in the process, had met the accreditation standard, but still said, this is really not a sustainable, workable system. You know, it's a great document. The patients really appreciate it. We think it's a good plan, but, you know, depending on your technical capability and your staffing may change the ability to create these on an ongoing basis. And so Commission on Cancer took that out as a requirement for accreditation. And as I said, starting under the new standards, rather than looking at just the creation of the single document as an accreditation standard, it instead is going to start expanding their accreditation to include survivorship care programs. So they're of which the care plan is only one particular aspect, which you can or cannot do depending on what you're thinking. So as I said, when we do the roundtable next Tuesday and you all have a chance to input into the discussion, it'll be really great to hear where you all are landing on using the care plans as part of your accreditation package going forward, or how you're modifying your survivorship program.
Yeah, and another issue we found, again, we said it several times, is just it's very time consuming to complete one of these forms. There's really no reimbursement for it. And the survivorship care plan is kind of a point in time. It's the patients here today. Let's give them a summary of everything that's happened, everything they need to do going forward. Well, we all know plans change. So without having an interoperable document that can be shared down the road with other providers of care, there's really becomes a lack of clarity on who maintains that master document and how you update that document as the care plan changes. And it just again goes back to being a very, very time consuming document.
Correct.
So what we found as we were going through the project, that many of the fields that are needed in the care plan are captured in non-cancer specific EHRs, all the patient demographics, the diagnosis, the family history, procedures. You guys can see the list here. The CCD really is designed to be an all-inclusive document. It's supposed to share enough information down the road with other providers of care to at least know the patient's problems, allergies, meds, the basic care that patient has received. And the survivorship care plan goes so much more deep, goes into very specific information, past appointments, future appointments, the specific procedures, the type of oncology provided to that patient, that it makes it really, really difficult to map all that information to a CCD. At one point, the Commission on Cancer did try to map all of the fields in the SCP to HL7, which they successfully did, but then if you map that HL7 to the CCDA, you're just going to run out of fields. Also, the survivorship care plan, it's not a real-time document. It is a point-in-time document created at the end of a patient's treatment as a means of consolidating all the information. If that patient needs treatment not defined or not laid out in that care plan, then the thought is the care plan will be updated to that new care plan information, or the new treatment plan with that patient. So we've got a lot of limitations for true interoperability of the survivorship care plan. Not to say that sometime down the road we won't be able to pass that hurdle. It's just right now, given the limited data set of the CCDA and the broad data set in the survivorship care plan, we just weren't able to achieve true interoperability or anything really approaching it.
Correct. So what we did is we worked with Emily and we put together a white paper that covered all the work that was done, the question of accreditation, because there is the one group, the breast cancer accreditation program, does still require those survivorship care plans. So there was an issue about what should we do. We put together the white paper and came up with recommendations that could be sent from CDC to the Office of the National Coordinator, who does the certification for electronic health record systems.
I'm sorry, if you've just joined the webinar, if you can, try to mute yourself.
Okay. So you missed the recommendations. There you go. So the recommendations are really twofold, and we spoke of them, but knowing how CMS and CDC work when they get to setting standards and stuff, I'm a true believer in taking the time to actually send stuff up. It may not change things tomorrow, but it's funny how it comes back around. Scott and I do a lot of work on commenting on new programs, and it invariably CMS and ONC do come back and comment on what you've said. And so I'm hopeful that maybe they will look at this. Our two recommendations were either, first of all, to create a oncology specific certification program. And what this would do, even with all the various fields that you all track for breast cancer or prostate cancer or lung cancer, whatever it might be, they're going to be very specific for that particular diagnosis. But if you set a requirement for certification of the system, then you would force all the various vendors to sit down and come up with some common elements that could be discreetly pushed into a document that could then be shared amongst providers. So that would be the first possible way of going forward. The second way, and this was really after we had talked to the Epic sites, really made us think about what it was that was the barrier here in if you are able to create decent survivorship care plan, which, as I said, all of you are doing. It was a question if the barrier is not creating the survivorship care plan, but in transmitting the survivorship care plan, what could we recommend that would allow that transmission to occur? Because right now, even if you have a document, there is no good way to move it into to a provider who does not have a system just like yours.
Yeah, so the folks are still sending these via fax. They're handing them to the patient who's then carrying them out. So, granted, a PDF file is not interoperable, but it's better than nothing.
Yes, and if the goal is to, and I mean, you have two things that you achieve that way. If you could have a document attached to a direct transmission, so email transmission, you could send it either to the patient or you could send it to a subsequently treating provider. And this would probably take less work than remapping to a whole oncology specific certification program. And I think it's pretty realistic because there are one or two vendors that currently do allow a document other than a CCD to push when you're sending something via direct email between one site and another. And so it can be done. It's just a question of allowing it and creating the standards and then the review by ONC when they go to accredit a system that would say, show us that you can transmit this.
And the direct protocol is intended to be a secure email system that allows for both a message from the provider, a CCD, and other file formats to be attached to that message. It's just some of the EHR vendors have been very restrictive in the means that they've implemented that functionality, allowing only for a CCD document to come through and stripping out the additional documents or rejecting it wholly.
Okay, so as we had mentioned to you all in your invites, this webinar is really a companion piece to a roundtable next Tuesday that will be an hour long. That is really, all of you are experts in this area. Scott and I were newbies coming in on this particular project. We learned so much from all of you. But I think what might be really helpful, Emily's done a beautiful job in laying out the program and the move to create a new cancer plan for the state. And so I think this would be your chance to kind of talk together and give your thoughts on survivorship care programs versus the use of a care plan, whether you are going to continue to use the care plan, whether what's your feedback. A lot of you gave us very interesting feedback on the patient perspective of using it, and what you think generally the state should be aware of as far as how survivorship programs are moving into the next decade. And so we're very pleased to have you all join us on Tuesday, and you're all welcome to unmute yourselves and comment on anything that you feel like, and I'm sure Emily would appreciate it.
Yeah, and this session is really intended to be a bi-directional discussion. We want to hear from you. We might have a few slides just to kind of trigger the discussion, but this is your chance to give feedback back to ODH, back to us on how this program can be improved across the state.
Correct. So we're going to unmute Emily here to see if she has any last words.
Give me just, all right, Miss Emily, you are unmuted.
Okay, I just want to thank everyone for taking the time to attend today, and I hope that you'll all consider joining on Tuesday, and I'm looking forward to that discussion and collaborating with all of you on ways that we can work together. Thank you.
All right, now looking at the questions, we don't really have any. There are some questions about will we send out slides? Absolutely. We'll send out the white paper. All of our contact information is available on this slide, so feel free, if you have any questions after, email Cathy, email me, email Emily. We would all be happy to respond and provide you with any additional information.
Yeah. So thanks so much for joining us. We appreciate it, and hopefully we will talk to you on Tuesday. You have a great day.